Well, thank you very much for that very long introduction, Dr. Weinstein. It's always a pleasure to be invited to beautiful countries like Israel, so thank you very much for the invitation. And particularly if it's on an important topic, and frankly, the first two slides of today, if you heard nothing else, you'll have, I think, gained an enormous amount of important information about not just the burden of heart failure on patients and healthcare systems, but the risks that this burden is set to increase. Well, I've been asked to talk about the initial assessment. My clinical practice is actually as a GP, but my research interests have for quite a long time been on heart failure and atrial fibrillation. And I'm just really going to focus on this critical issue, which is getting the diagnosis right from a community setting, because I think once you're in a hospital system, it becomes usually reasonably evident if a patient has heart failure, but presented with undifferentiated problems in the community, how do we more accurately determine whether a patient's presenting symptoms actually relate to heart failure or not? Ooh. Right, so I'm just going to make just a few points to start with in relation to the importance of heart failure. Obviously, I'm going to replicate some of the very important messages from Dr. Gottsman, but I hope you forgive me for that, because I think they're important points. I'm just going to reinforce the fact that this disease is a disease of the elderly. These aren't data you've seen thus far. It's the ECHOES cohort. This was a very large epidemiological cohort I established about 15 years ago now. And it benefits because it is based on a screened population, a general population in the community. And therefore, it's probably as accurate as you'll get, at least in the United Kingdom, determination of what heart failure prevalence is, because we screened patients who had not been identified and asymptomatic patients, obviously, as part of the program. And you'll see, actually, that in the over 85-year-olds, the prevalence is actually even greater than the important international data that Dr. Gottsman summarized, which suggested about 11% of patients over 80 suffer heart failure. In fact, in our series, it was 15%. So it's very much a disease of the elderly, and that's important, obviously, because, as Dr. Gottsman's already pointed out, the proportions of the elderly in the population are set to rise. He also pointed out that the other major driver of heart failure, patients surviving infarction, is improving as well. We're getting better at helping patients survive events, but inevitably, if you suffer infarction, you're going to damage your ventricles, at least to some degree, and those patients are going to be at increased risk of getting heart failure, plus the increasing burden of risk factors in the population. And in some ways, it's surprising that those data haven't impacted more on health policymakers, because what this meeting is about is physicians and nurses and other healthcare workers becoming more aware of heart failure. But why haven't health systems themselves, the public health focus of the country, become more concerned? Because it is a rising, predictable burden. Let's just focus on patients for a minute, though. You saw the data suggesting it has a prognosis worse than cancer. That was John McMurray's data, looking at patients diagnosed during a hospital admission. But these are data from ECHOES, so again, it includes undiagnosed asymptomatic patients as well as symptomatically recognized ones. And if you look at the follow-up data, we've now got data going out more than 10 years, then it is a very mortal condition in terms of only 30% survival at 10 years. So even on an age-adjusted basis, a highly significantly condition associated with significant mortality, perhaps not quite as severe as John McMurray showed, but this is including the asymptomatic population as well. It's not a condition that we wouldn't want to intervene in to extend life. And these data are based on THIN, which is the electronic health record of about 4% of the UK population, so it's routinely collected data and looks at all of those patients who've got a label of heart failure in general practice. And basically what it shows is that 1, 5 and 10-year survival of patients with heart failure in the UK isn't changing. So despite all of the attempts we have at intervention, in fact, we aren't improving long-term prognosis of patients, at least in the United Kingdom. The other thing that we probably should reinforce at this point of the meeting is the impact of heart failure in terms of symptomatology and quality of life. It does, for patients with more severe symptom, have quite profound consequences. This was a public awareness raising campaign by the British Heart Foundation. It didn't last very long. There were complaints about it from the public and they had to withdraw it after a week. I think sometimes shocking messages are too shocking for the public. But I think these data are interesting. It's slightly complicated, so I'll just run it through. This is looking at quality of life measured by SF36 that looks at 8 modalities of life: role functioning, role physical, role mental, social functioning, mental health, energy levels, pain, and overall health perception. And what we've done here is convert these scores by patients with these chronic disorders taken from the entire ECHOS cohort, and we're able to standardize it to the population who didn't have those chronic diseases. So it's quite powerful data because it's standardized to the same population. And traditionally with a Z-score, a difference of 0.1 is a clinically significant difference. And what you can see is grade 3 and 4 heart failure in purple here has very clinically significant worse quality of life on all modalities other than mental health, where obviously depression is worse, or pain, when obviously arthritis is worse. The heart failure is not a painful condition, but it does very significantly interfere with quality of life. Why? Because patients get less exercise ability, reduces social functioning, produces social isolation, and generally makes people feel more miserable. And also to reinforce this point that it does have this big impact on health systems because it's the commonest cause of admission and readmission. And if there was one reason for the public health systems to take more notice of heart failure, it's that observation, that if we don't do more to try and prevent or intervene more quickly or be more effective in management of patients with heart failure, then we are going to increase healthcare expenditure. Given that heart failure is about half as prevalent as diabetes, and most health systems have lots of things in place to actually diagnose and manage patients with heart failure, with diabetes, it's surprising that there aren't more structured programs available to assist practitioners cope better with heart failure. So what I'm going to focus on for the remainder of my talk is this initial assessment and diagnostic issue, and what's the best ways of approaching that from a primary care point of view, i.e. when you're dealing with relatively undifferentiated patients. And I'm going to particularly look at whether clinical features can improve the selection of patients for echo, and the role of ECG and natriuretic peptides, and just a brief summary on acute heart failure as well. Well, as we know, the symptoms that patients get with heart failure, things like dyspnea, orthopnea, edema, are common. And as a consequence of that, if you actually look at the sensitivity and specificity of tests or clinical signs or elements of clinical history such as MI, you'll see that the ones that have relatively high specificity tend to have low sensitivity or vice versa, and their overall predictive scores are poor. Indeed, if you look at something like myocardial infarction, you can see it's a very specific sign about you won't, it's very high specificity, but it has a low sensitivity, so you will be missing many patients if you only relied on a history of MI to determine who you referred for investigation. What about the role of ECG? Well, you can see here its sensitivity and specificity are relatively poor, so its area under the receiver-operated curve, which assesses its overall function here, is modest. And if you look at BNP, just using a BNP test performs much more highly. And in fact, if you combine the two, use the BNP and ECG, you gain very little. ECG does not improve the accuracy of a heart failure diagnosis if you have access to a BNP test. Well, I showed that individual symptoms are not very helpful. What about if you try to cluster the systems together, developing a clinical decision rule? And there have been a number of studies that have prospectively looked at clusters of symptoms and seen how predictive they were of a subsequent diagnosis of heart failure. And I'm going to present two from the Netherlands and one from the UK. Kelder showed that actually if you use their model, which gave various weighted scores for over 10 different clinical characteristics, you actually, at the top range of scores, were very accurately predicting heart failure, but it was extremely complicated and includes lots of additions of really odd numbers like 71 and 42, etc., i.e. it really isn't intuitive, even if you're using an electronic system. They tried to revise the score into fewer modalities that retained its predictability, but again, just far too complex for routine clinical practice in terms of the number of things you're going to have to measure and then the number of additions you'll need to make, and even some of them making a subtraction. Now, we looked at this. We did a systematic review and meta-analysis of prospective screening studies and studies of patients into an early access heart failure clinic to see which of the symptoms associated with those studies were predictive of heart failure. And we developed, as a consequence of that, the MICE rule, MICE being that you should refer straight to echo from the community if a patient had a history of myocardial infarction or basal crepitation, or in men, peripheral edema. And in other patients, you should basically do a natriuretic peptide test, and we produced two cutoff scores that were predictive of heart failure. Well, that was based on epidemiological studies, and so we went on to test this rule in a prospective population of patients in primary care who the GP felt had symptom clusters that might be associated with heart failure, i.e. recent onset shortness of breath, lethargy, or ankle edema of over 48 hours duration with no obvious cause, where there was no symptom that required immediate management. And clearly, the GPs in this situation might or might not, under normal circumstances, have referred the patient to hospital. Well, we basically did a natriuretic peptide test and made sure all the patients were referred for a research echo and derived the MICE score, and then had quite a complicated staging of presenting the symptoms to specialists so that we could determine the characteristics of these different ways of approaching the diagnosis. And suffice to say that unfortunately our MICE clinical decision rule performed no better, in fact performed worse, than simply using the natriuretic peptide alone. And we looked at two cutoffs with, this was NT-proBNP, one of greater than 125 picograms per mil, and one greater than 400 picograms per mil. If you used the 400, you're basically producing a more specific test. You're going to have fewer false positives, but actually you are going to miss 1 in 4 patients who actually do have heart failure. And this is quite an important dynamic, because if you're in specialist practice, what you want is a test with very high specificity, because you want to be ruling in disease. But by and large, in primary care, what you want is a test with high sensitivity. You don't want to be missing cases. And if you used NT-proBNP, you'll be only missing about, of 125, you'll only be missing about 5% of heart failure cases, but about 1 in 2 will not have heart failure. So you're using it as a staging test, not as a diagnostic test, but a staging test that has more precision than just using clinical symptoms or an ECG. And indeed, pleasing for the ESC, that's exactly currently what the ESC recommend in terms of the diagnostic triage, which is that you should either refer, if you have a suspicion of heart failure, you should either refer straight away for echocardiography, or if you don't have immediate access to that test, then do a natriuretic peptide, and if it's above 120 picograms per mil in the terms of NT-proBNP, then you should assume that the patient has heart failure and refer on to echocardiography. Now, this is an important point here, this transition, because if you have a system like the US, probably spends 3 times as much on healthcare as Israel, 4 times as much on healthcare as the United Kingdom, then you're just routinely going to get access to echo. It's not an issue. It's a high cost, high investigative environment. But if you're going to be in an environment where access to tests is more restricted, or has to be via a specialist consultation, then you need to think about how you're going to improve the clinical pathways. It's quite important, I think, for primary care to have more access to open access to investigations, so that you don't have to see the specialist too. Why? Because specialists are a rare commodity. You'll be swamping them if you're sending more cases that may not have disease, and it's a more costly referral pathway as well. So I think for most health systems, they need to increase the access of primary care to investigations such as echo, but you don't want that service to be swamped. So what can you do to have an intermediate step that increases the likelihood? And in this instance, in heart failure, we do have natriuretic peptides that will produce a more cost-effective pathway to open access to echocardiography. Interestingly enough, NICE in the UK currently recommend a cutoff of 400. That might be more cost-effective for the health system because it'll reduce the number of patients being referred for echocardiography, but it will miss, as I said, it'll miss a quarter of the cases of heart failure, and we've certainly been advocating that NICE reduce their cutoff to above 125 as in the ESC. Now, just a quick slide on the furosemide diagnostic test. You may believe that that is dead and gone, but this is actually still quite commonly utilized by general practice in Europe, at least. This is a study based in the Netherlands. Netherlands has very high quality, very well-trained primary care, and yet this was based in 2010. When they looked in 2010, 70% of GPs thought that a furosemide diagnostic test was a useful test and had used one in the previous 12 months. And yet, when it was prospectively tested, it was completely useless at determining whether or not the patient had heart failure or not. So that it really isn't an option to you, the treat and see strategy. So in conclusion, for chronic heart failure at least, clinical features you'll use in determining the sorts of person that you've got a suspicion may have heart failure, but you're not going to use that to determine whether or not to refer. That's a very important point. If you suspect heart failure, you need to make a more reliable diagnostic assessment, and that means either a referral if you want to spend a lot of money, or an echo if you have access to that immediately, or more likely you'll want to get the natriuretic peptide done. And here in Israel, I heard that even hospitals don't routinely have access to natriuretic peptides. It should be routinely available to hospital specialists, but even more importantly, available to general practitioners as an open access test in order to improve the proportions of patients who then get filtered through the system for accurate phenotyping. Just a quick word on acute heart failure. The ESC suggests a cutoff, again, of NT-proBNP here of greater than 300 picograms per mil, and a meta-analysis that looked at all of the prospective studies indeed has confirmed that that is the right cutoff with a very high overall predictive score. So I think my conclusions, therefore, are in terms of diagnosis that natriuretic peptides, frankly, are an essential part of the clinical pathway of determining those patients ultimately who have heart failure. It isn't of itself diagnostic. You need to image the heart. We're going to need more sophisticated methods of determining preserved systolic function heart failure. We still haven't got completely reliable diagnostic criteria for that phenotype yet, but you'll need to do an echo which will help determine the cause of the heart failure and to help stage the heart failure. But the natriuretic peptide will improve the throughput of patients who need access to that investigation. And the clinical features, therefore, should be used by you to determine who you do a natriuretic test in, but not to decide who you don't get the test done in. They are conflicting and unhelpful in that degree. Now, before I finish, I've just got two more slides, because we've already heard about the importance of evidence-based treatments in heart failure. These are data that are relatively old now, but actually more recent surveys appear to show similar levels. The only reason I show this one is because it's a very, very large data set across 15 countries, basically showing that in terms of ACE and ARBs, a high proportion of the population actually are offered these evidence-based treatments, but you'll notice that fewer of the elderly actually get access to those treatments, and they're the groups that are most likely to derive benefit. But the big issue we've got is with beta blockers. This replicates the data you saw earlier on as well, which is that probably only around a third overall of patients eligible for beta blockers are actually on them, and far fewer women and people who are older with heart failure are exposed to beta blockers. And there was a very useful IPD meta-analysis in the Lancet just this month, which showed that basically women derive as much benefit as men from beta blockers in terms of reducing mortality and reducing hospitalizations in association with beta blockers. And very importantly, that the age and gender of a patient did not affect the likelihoods of having to stop, because the other big issue about this is that this is the numbers of patients initiated on beta blockers. A third of patients initiated on beta blockers with heart failure stop it within 12 months. So we've got an issue about not exposing enough patients, but also withdrawing it because of perceived adverse effects more than we should. And yet the trial data suggests that they are tolerated just as well in the elderly, and if you're female, than in other groups. So I hope that the staging of patients at that initiation is more clear, and I thank you for your interest.